Thanks for joining us for another SRS podcast. In addition to myself, Jeff Mullin from University of Buffalo, we also have Charla Fischer, also hosting from NYU. Our honored guests today are Justin Smith from the University of Virginia, who unfortunately had the pleasure of being one of my mentors for a year when I was in fellowship with him there. And then Dr. Isador Lieberman from Texas Back will be joining us. They'll be presenting their papers, which were the recent award winners of the Whitecloud Awards.
Just a little background on the Whitecloud Award. So they were named after Thomas E. Whitecloud, who helped found the IMAST. And so the way the Whitecloud Award winners are selected is they're nominated by the IMAST committee from the submitted abstracts. They're invited to submit a manuscript, and then during the virtual meeting, the presentations are voted on by the attendees. And so the manuscript evaluation plus the voting, then the IMAST committee selects them, and it's quite a huge honor. So we're very excited to talk to our two guests today about these award-winning research projects.
So again, congratulations. This is pretty informal. Hopefully we have a nice conversation with all four of us chiming in, and we'll go over each paper one at a time. We'll start with Dr. Lieberman's paper, which is what is the actual happening inside the cone of economy, compensatory mechanisms during a dynamic balance test. This is a pretty interesting study, which I've not seen much like this anywhere else. So maybe Dr. Lieberman, start off telling us a little bit how you got involved with this and what you think research is significant for, and next couple steps.
Thank you, Jeff and Charla, for inviting me. It is our honor to be here and to be able to contribute to the SRS podcast. And Justin, it's awesome being side by side with you presenting our papers. So at Texas Back, we got involved with gait studies about 7 years ago now. It kind of started on a whim. We wanted to get a little more exposure to functional outcome measures. For a long time, we have been very reliant on the patient-reported outcome measures. And yes, they're important, but myself and a number of my colleagues realized that when the granddaughter is filling out the patient-reported outcome measures in our waiting rooms, it's really not that valid. We brought on a basic scientist, biomechanical engineer, Dr. Hadas. We brought another one on, Damon Marr. Quite frankly, the two of them should be getting all the credit for all of this work that we've been doing over the past 6 years. They have just been absolutely remarkable in terms of building the GATE lab and collecting the data and getting things going. Within the GATE lab, we can measure multiple modalities. We use 3D video capture. We've got force plates to measure ground reaction forces in the floor, and we've got a walkway. We've got a 30-meter walkway that they can walk back and forth on with force plates in it. And we also do fine wire and surface EMG. So we've got all the different modalities that we can measure. The interesting thing is how the technology has really changed over the last 6 years. And now looking back with what we are doing and what we have, it's actually pretty primitive technology considering the remote sensors that there are now, the various IMUs, the inertial monitoring units that we can use. So there's so much more convenient methods than what we've been doing traditionally. We're starting to migrate into that. My practice is predominantly revision surgery and adult degenerative scoli with enough adolescent scolies to keep me sane. And within that deformity group, we've noticed that the patient-reported outcome measures really aren't indicative of how those patients are truly doing. And that's where we started. So we started collecting data before and after surgery on all our patients, and we put them through the GATE lab study, looking at their kinematics, looking at their spatiotemporal parameters, and trying to figure out, am I really making these patients better? And much to my satisfaction, I was able to justify my existence. We really are making these patients better. They walk better, they stand better, their posture's better. But the first foray of it was pretty much just straight up and down gait and what they're doing. And then as Damon and Rum got much more experienced with it, they started looking at the dynamics behind it and what's happening to the patients. How are they compensating? What's going on in the hip joints, in the knee joints? And really, this is where this paper came from. Everyone is familiar with Jean Dubosset, one of the giants in spine surgery and deformity surgery and adolescent scoli surgery, and he defined the cone of economy many years ago. So our first step was really to measure the cone of economy, and we've published a couple papers on that, looking at the dimensions of the cone of economy, and we've been able to compare that to different pathologies and to what patients can and cannot tolerate. And this paper represents the evolution of that to try to find out what is happening inside the cone of economy. So we've got our patients, they want to stand as balanced as possible, but if they've got a coronal deformity, they have to compensate somehow to keep their head over their center of mass, or else they're going to fall over, or they're going to expend way too much energy trying to stand upright. And that's really what this paper has done. It measured what's going on at the hips, at the knees, and looking at the compensatory mechanisms that our patients are using to try to keep themselves balanced. One of the things that I've come to learn out of all of this is that the brain sacrifices alignment to maintain balance, to be within Dubosset's cone of economy. But what we're learning from here now is that the brain is instructing the hip joints, the knee joints, the ankle joints, the body posture to figure out how to do that. So we're measuring it as they are walking, as they are standing, and we can really see what's going on. And what we noticed here is that in the ADS patients, they do use more of what's called a hip compensatory mechanism, where they flex their hips to bend forward. And this is what we've recognized as surgeons as the typical flat back posture over all these years. But it's a compensatory mechanism. And now we're picking up the data to show when we realign the spine, they are normalizing. They don't get back to normal, but they are normalizing these compensatory mechanisms. And that's really what this paper is telling us, is what our adult degenerative scoli patients are doing to keep their balance in the cone of economy, and comparing that to our control group as well.
That's great. It's very interesting. Just for the listeners who maybe not have a chance to look at this paper in front of them, I thought it was interesting how just the setup you have looks like patients were getting made into video games like EA Sports does, with little electrodes all over them and sort of measures every movement. So it's very interesting from that standpoint.
Yeah, I think this is a wonderful paper, Izzy. And when we assess these patients, I'm often concerned that we really look at them in an artificial way when we get x-rays, and they're often standing at their best. And looking at them in motion, I think, is really valuable, because patients don't live standing upright, erect, in perfect position for an x-ray. That's not how they live. And how they function and do daily activities is critical in order to better understand how we should be aligning those patients. And so I'm curious what next steps you plan to take with this dynamic alignment analyses. Do you see carrying this into some kind of a classification, or applying it to treatment approaches or outcomes measures?
So thanks for those comments, Justin. This is a very, very interesting field, and we're just scratching the surface right now. One of the things that we have struggled with is the volume of data that we are generating, and we really don't know what to do with it, and we're getting overwhelmed with all this data. So we do have to sit down and, as you pointed out, figure out what's important and how we're going to use that for treatment. So I can give you my bias, my impression of what I think we're going to be doing. We are taking the next step, looking at dynamic alignment as the patient goes through the gait cycle. So what's their pelvis doing when we fuse to the L5-S1 level? What's their pelvis doing if we're only fusing down to L4 or L5, leaving L5-S1 free, and trying to figure out differences if we can get them still balanced and they're moving better. So these are the next steps that we can use. We're also going to try to use this data to validate some of the different finite element models that are out there, to show that the finite element models really mimic what we measure in the gait lab. Now, to Jeff's comment, yeah, our patients, we suit them up. We put all these reflective markers on them. We poke them with wires and sensors. It takes about 45 minutes to set them up for a gait study. And some of these patients can't tolerate that. But now there's so much better technology that it really is changing the way we're going to be doing this. And we're going to see different types of monitoring units that we can just strap onto the patient. It's going to take what's a 45-minute setup to a 5-minute setup. And I think the next step when we get that technology refined is us using it in our office. We're going to examine the patient. It'll be an extension of the patient examination. And then we'll be able to say, okay, look, you are flexing at the hips, you're locking your ankles, you're trying to walk, but you're swaying too much side to side. If I correct the coronal balance, I get your head here, you should potentially be eliminating that. So that's what I see as the future of something like this, with office examination to define the most appropriate treatment.
Okay, great. I just had a question about one of the comments you made in your paper, that a lot of the standing radiograph studies have been discussing pelvic retroversion, and maybe this hip flexion movement that you found, it may not sort of make sense with both the pelvic retroversion. So I just wanted to give you an opportunity to discuss the more dynamic pelvic and hip action that you saw going on.
Yeah. So the one thing with all our spine patients is everyone that's got a bad back almost certainly has something going on in their hips as well. They're at that age group, they're going to get it. And you have to assess the hips. I learned very early on in my career from one of my mentors that the best spine operation is very often a total hip replacement. So we look at the hips and we try to monitor. Now, what happens when the pelvic retroverts? The hip goes into apparent extension. If it's an arthritic hip, you're losing that extension, which accentuates the flat back type deformity and the so-called hip spine syndrome that we've been sort of rudimentally recognizing up until now. Now our orthopedic hip and joint colleagues are understanding this. We're starting to understand it and get better at it. So I do think with the dynamic motion, we're going to be able to tell what we do in the lumbar spine is going to position the pelvis in this space, in three-dimensional space, and it's going to allow the hips this much range of motion to keep them balanced so they can compensate easier. Or, you know what, if I do this, they still don't have enough hip extension. They're still going to be pitched forward. So we've got to look at all of those things. So that's where, and Justin mentioned it, the static radiographs, we are being misled a lot of the time by what we see on x-rays.
Great. Maybe I'll ask one more question and then we'll get moving on to the next paper. So I think this is fascinating technology. I think we'll only keep advancing. To your point about how we'll use it for almost diagnostic measures during an office visit. Do you think we'll get to the point where we can use this for sort of evaluate, this patient has a myelopathic gait versus something else? Talk about the hips and the lumbosacral relationship. Is some sort of diagnostic for SI function as well?
Absolutely. You've touched on a lot of the hot spots that we're already working on with this. Cervical spondylitic myelopathy. Everybody knows the clinical manifestations of that. Everyone can see it. We really don't need to measure that in a gait lab. What we don't know is their physiologic reserve for recovery. And that's what we are trying to figure out right now. The issue that we're having, patients with early myelopathy, they're easy to measure. And after surgery, we can measure their improvement very easily. But we're seeing patients that are essentially wheelchair bound that we can't do a gait analysis on. They can't walk. They can't get up. So we don't have that severe cervical myelopathy group that we can say, okay, look, this is a group that's this severe. They don't respond. They're not going to have the ability to physiologically recover. So that's one of the shortcomings that we're dealing with now. We are looking at SI joint pathology, and yes, it's very interesting. We can measure differences in SI joint pathology from one side to the other on the basis of their gait, the stride length, the step time, and we can see these differences. So I do think it will be diagnostic in that regard as well. And likewise, we're doing things with total disc replacement. We're doing things with disc herniations, spinal stenosis. trying to figure out what are the predictive parameters that we can measure ahead of time to, one, justify surgical intervention, and two, prognosticate on the result of surgery. And I envision this all leading into a lot of the AI work and the predictive analytics work that's coming down the road. So it's all going to be bundled together. And this is just one small aspect of it that we have to keep developing.
Great. Very interesting. We'll switch gears a little bit and move on to the other part of the podcast. Dr. Smith will be presenting to us some of the research coming out of the ISSG, the International Spine Study Group. Their paper was the prospective multi-center assessment of complication rates associated with adult cervical deformity surgery in 133 patients with a minimum of 1 year follow-up. So without further ado, maybe Justin, you could talk to us a little bit about your paper.
Sure, happy to. I would echo my thanks to Jeff and Charla for putting this podcast together, and it's a pleasure to be on this podcast with Izzy. I've been a member of the International Spine Study Group since its founding about 12, 13 years ago now. It's been a very productive group because it's truly a working group of like-minded individuals who really want to advance the care of adult spinal deformity patients. And I think most people recognize the ISSG for the work that we've done in thoracolumbar adult deformity. And we had a very large database. That was our initial database that we started with, was a prospective, operative, and non-operative outcomes database for adult thoracolumbar deformity. But a few years into our work, we realized that there's another segment of adult deformity that this really has not been well studied, and that's cervical deformity in the adult population. And so we started a separate prospective database to collect cervical deformity patients. And this is something that's unique. I'm not aware of any other prospective cervical deformity database assesses these patients. There have been a number of retrospective case series, and back in the early days when adult cervical deformity was published and studied, it was really focused on the most severe cases with limited surgical approaches and techniques that had very high complication rates and was not deemed something very favorable. But a lot of technology has improved. Our ability to care for these patients has improved as well from an intensive care standpoint and an anesthesiology standpoint. And many are starting to gain an interest in treating these more complicated cervical deformity patients. And so we started a separate database specifically to collect cervical deformity patients. And we've collected about 140 patients to date. One of the early studies we did was to see how these patients are impacted by their disease. And so these are patients all coming in for surgical treatment, but we found that these patients, when we compared them to other chronic health conditions, that these patients really were comparable to very poorly functioning patients with emphysema, renal failure, stroke, or other very significant health conditions. Some of these cervical deformities can have very profound impacts on patients. Their ability to maintain a horizontal gaze and interact with the world, their ability just to hold their head upright, or there can be significant neurological issues as well, can compromise the ability to swallow, for example, or even breathe in some of the severe cases. And so one of the studies that we did was to look at complication rates. And that's the subject of this study that we're talking about today. And that is to look at what complications occur with surgery in this patient population. And really the true value of looking at complications isn't just to report numbers, but really to identify trends. What are the common complications, with a goal of trying to come up with ways to reduce these complications and to make these procedures safer and more effective treatments. And what we found in this study, we had 167 patients that were enrolled, and 133 had a minimum 1 year follow-up time. And when you look at complication rates in these patients, really the most common complications that we saw were cardiopulmonary, respiratory failure, for example, pneumonias, other cardiac events. And this really reflects that this is a special population. This is a very frail population often that develops these cervical deformities. And it's very different than the thoracolumbar deformity population. And some of the other common complication categories that we saw were neurological, including nerve root deficits and radiculopathies. Fortunately, spinal cord deficits were very rare in this series, but those can also occur. And we saw a number of patients with significant dysphagia because these treatments are often complex and involve realignment of the spine that may stretch the esophagus or create other GI issues. And we also saw a number of radiographic complications such as distal junctional kyphosis. And in the thoracolumbar population, we often see proximal junctional kyphosis. But in the cervical deformity population, we're often looking at failures at the other end of the construct, at the distal end. And a number of these patients require revision surgery for those distal junctional failures. We also saw a number of infections and operative complications as well in this patient population. And so really this study sets some landmark or baseline benchmark complication rates that we see in this patient population and really sets the stage for the next phase of our work. And that is to try to define ways to reduce these complications. And we've been very effective in helping to contribute to reducing complications in the thoracolumbar adult population through a similar approach. We did some complications analyses in the thoracolumbar adult population, and we saw that proximal junctional kyphosis, rod fracture, and infections were common complications. And we've helped to define multi-rod techniques to help reduce rod fractures, finding tether systems and techniques to try to reduce proximal junctional failures, for example. And so now we really need to turn our attention to the cervical deformity population and try to define ways to reduce these complications and make these procedures safer for what really is a very frail population. And so that's the work that we did in this study. But it's really just the beginning of future work. And we're actually initiating another database where we are essentially starting from scratch. And we take what we've learned from this first prospective cervical deformity database. We've started over and we're collecting a number of other outcomes measures. And we're planning to follow this second group of patients out to 10 years in order to really see the durability of these procedures and the impact of these treatments on these patients. And so there's more to come. This is really a first step in a long process.
Great. Thanks so much for that summary and all this work. And you really went through a lot of the questions that I was going to ask. So that was a really great synopsis of this study. Okay, so just correct me if I'm wrong, but from what the gist of what I'm reading, about half of your patients had no complications and the other half had about 1 to 7 complications in various systems. So what advice do you have to a surgeon who's about to embark on a case like this? What to expect, or what kinds of things should they be evaluating preoperatively to make this as safe as possible for their patient?
That's a great question. You know, as I mentioned, this patient population really seems to be fairly frail. You know, and we looked at another study we looked at was all-cause mortality in these cervical deformity patients who were treated surgically. So it's not the non-operative ones. These are the ones coming in with significant impact and they're seeking surgical treatment. And fortunately, there weren't a lot of deaths directly attributable to surgery, but there were a few. But if you follow these patients out to a year, 2 years, you see that there's about a 10% all-cause mortality rate. So this is a very frail population that we start with. And if these patients weren't so impacted by their disease, we'd be tempted to just leave them alone. But they are very impacted often by their disease to the point that many of them just don't want to even live in their current state because of how impacted they are.
Yeah, you mentioned that they have similar quality of life measures of like blindness, low vision, emphysema, renal failure, and stroke. So they're a comparable, miserable population.
Absolutely, absolutely. Which brings me to the answer I have for your question, is that when we evaluate these patients and decide on whether to operate on them, it's important to remember there are still situations where you should say no, where a patient is just too frail for surgery, where you're probably only going to make them worse potentially with complications in that. So it's recognizing the limitations. The second I would say is trying to optimize those patients as much as possible. Their bone quality, for example, if they have osteoporosis, if they're smokers, getting them to stop smoking to try to maximize their chances of bone healing. And then carefully assessing their alignment, looking at what's in the literature and learning about what alignment should be in the patients so that we try to get them in a good position and reduce the chances of having mechanical failures.
Great, that's awesome. The ISSG, if you look at your co-authors, some very excellent spine surgeons in the field of cervical deformity. Do you think these results are generalizable, or are these sort of the ideal case scenario results?
Well, looking at the number of complications that are there in this series, even though, as you say, this is a very experienced group of surgeons, the complication rate is very high. So it's a challenging surgery, these aren't cases necessarily. I wouldn't recommend that someone just do the occasional chin-on-chest deformity, like one a year or one every 2 or 3 years. If someone wants to really get into significant cervical deformity surgery, they should buy into it and actually do many cases and learn about it and pursue it aggressively rather than just dabbling in it. So when you say is it generalizable, to someone who maybe just does one every 2 or 3 years, I would say that these results probably aren't generalizable. But I think to the adult deformity surgeon, these probably are generalizable in that group of surgeons.
Maybe I'll just add a follow-up comment on Charla's comment about the group. And I think a lot of the stuff that we do in spine surgery can be done adequately by most. But when you've got cervical deformity or cervical thoracic junction, that is really the elite league as far as I'm concerned. I think that should only be done in centers that have the resources, have the ICU, and it's more than just the surgeon. You're talking anesthesiologist, you're talking rehab, you're talking metabolic bone treatments. There's so much there, and do not take this for granted, because there's no forgiveness. This is like climbing a mountain. It will not forgive you. The mountain will hit you back. So you've got to be right on with it. And this is elite league spine surgery.
And you see even the high complication rates in experienced surgeons here too. As Izzy's saying, that's well said. That's not a very forgiving population when they're that frail. There's so much room not only for surgical complications and mechanical failure, but all the medical complications in this relatively frail population. So having the critical care support, you're absolutely right, is very important in this patient population.
Very good. I think all of us are just taking away, big takeaway here is this is real surgery. Patients are sick, and hopefully we can use this paper to help us counsel patients who we are considering doing surgery on. And like you said, some patients probably shouldn't be getting surgery even in the best of hands, as your study group was there, because there's major complications.
Can I ask one more question for both of you? So I know both of you are huge mentors, and thank you for that. Can you just give some general advice to young deformity surgeons?
It's being like a sponge. When you're working with your mentors, your teachers, you absorb absolutely everything you can. And then at the end of fellowship or at the end of residency, but it's really ongoing throughout your life, you wring out the sponge every once in a while. And what's left in the sponge, that's what's important. That's what makes you the spine surgeon. And I know I've got stuff in my sponge from John Costwick, John Webb, Tom Wright, John Graham, all the guys that taught me how to be the surgeon that I am, and I'm indebted to them every day.
The advice for young deformity surgeons, I think, learning from your mistakes and trying to be humble. You get good outcomes, you're going to get bad outcomes, and just trying to always do what's right for the patient, I think is the advice I would have. And I've learned tremendously along the way from Chris Ames, from Chris Shaffrey, other giants in deformity surgery. And I think trying to take what you can from those mentors and then applying it into your practice, and then continuing to learn, because you'll never learn everything from a fellowship or from a residency. Really, you learn most along the way in your own practice as you go. And sometimes you learn from your own mistakes, but learning from the mistakes of others can be helpful too.
That is definitely sage advice from two definitely seniors in our field. So thank you both for that.
Yes, thank you.
All right. Thanks, everybody. Have a great night.
Thanks, everyone.
Thank you.
Bye.
The Scoliosis Research Society is a nonprofit professional organization made up of physicians and allied health personnel. Their primary focus is on providing continuing medical education for healthcare professionals and on funding and supporting research in spinal deformities. Please visit srs.org for further information.